All right. Okay, so this is going to be I like doing this because you give me a chance to practice out loud and see where I need to change things. The basic hormone replacement replenishment for men. This is going to be the first lecture in the AMNG sort of basic acupuncture. You got me saying acupuncture hormone workshop on October 19th. Are you coming or not? Are you going to be in Houston?
I am going to try, sir. I'm not sure if I'm on for the hospital that weekend.
Well, tell him to call me.
Okay.
Speaking of which, you see the slide here?
Uh-huh.
I made that with artificial intelligence. I think I'm getting better at it. Huh?
That is awesome.
Looks
Wow.
pretty good, I think. Huh? All right. So, again, no relevant financial relationships within other companies. Here are the objectives. We're going to do a brief testosterone primer, the basics, common problems and complications, prostate issues, erythrocytosis, 5-alpha reductase inhibitors, aromatase inhibitors, other complications, and I've got a couple of case histories in here too. Okay. So first off, when I've started us off right away, these are for men the amounts of hormones produced naturally at our peak, which is around age 25 to 27. And the reason I put it right here is that when we're going to dose things, this is the way to go. This is your guideline. So cortisol 20 to 30 milligrams. And we've talked about it before. Hydrocortisone, you usually should be safe with few to no side effects, as long as you dose hydrocortisone, not prednisone, hydrocortisone less than 30 milligrams. Testosterone 5 to 12 milligrams a day. I usually use 10 milligrams as sort of a round number, and that seems to work pretty well. For women, by the way, just as an aside, it's about 1 milligram per day, 1 to 3 actually. Androstenedione 3 milligrams per day, DHT 0.3, estrone 0.06, estradiol 0.045, DHEA 50. That's DHEAS, the sulfated one version. That's the one we measure in the blood. 15 milligrams of the plain DHEA. So again, just keep in mind, especially if you get lost in dosing, these are the physiological amounts that we make naturally at our peak. So testosterone is generated for males, 95% in the Leydig cells, 5% in the adrenal gland. There's it's a negative feedback. When the testosterone drops, it signals the hypothalamus to generate gonadotropin releasing hormone, to stimulate the anterior pituitary to produce LH and FSH. LH luteinizing hormone, and you want to keep in mind which of these hormones stimulate which part of the testosterone, sort of the whole milieu. So LH stimulates the Leydig cells, LNL. Leydig cells produce testosterone, which then goes on to stimulate the secondary sex characteristics. FSH, S, is Sertoli cells, and this is where the sperm is made. And this is what when we dose testosterone, especially in mid 40s, when there's fertility might still be an issue, it suppresses FSH and it shuts down these Sertoli cells. This is where you get your gonadal, testicular atrophy, and it sort of shuts down sperm production. Just to keep it in mind, and this is how this is the sort of the feedback. Testosterone is you need cholesterol. Remember, here we go again. On the outer membrane of mitochondria, it needs to be transferred to the inner membrane of the mitochondria via a steroidogenesis activated protein that it's called a star protein. It's the rate limiting step, and it's catalyzed by cytochrome P450. So, cytochrome P450 drugs, for the most part, can either stimulate testosterone production, and or cytochrome P450 inhibitors will inhibit testosterone production. The half-life is only about 12 minutes. This is the steroidogenic pathway. We've looked at this a million times. Hopefully, you know this backwards and forwards by now. You should know this as well as, brushing your teeth. And the issues that we're looking at here, remember, here's your cholesterol. This is how it's conjugated in the liver. This is where the star enzyme converts to pregnenolone, which then converts that 17-hydroxypregnenolone, D8 to DHEA. So remember, DHEA and pregnenolone are your precursors of testosterone and estrogen. They then converts to androstenedione to testosterone. Testosterone aromatizes to estradiol. That's where you get the estrogen issues. It also converts with a 5-alpha reductase to DHT. Remember, DHT is your potent testosterone, where most of the testosterone effects come from DHT, not just plain testosterone. And the adverse effects, hair loss and prostate enlargement. I just described that here. There's your aromatase, there's your 5-alpha reductase. If you go to the DHT pathway, it affects the prostate, the liver, and the skin, and it deals with facial hair, body hair, prostate growth, and acne. Estradiol affects the fat, the brain cells, fat, liver, bone resorption, brain function. Remember, estrogen drives blood flow to the brain. It's 220 adequate estrogen levels will dilate the carotid arteries and the brain arteries up to 224% with an adequate estradiol level at over 6 months. So that's kind of a breakdown of what happens with each of these enzymes. And as you know, we've used enzyme blockers to get different types of effects and certain types of side effects. So just as a quick question, I just want you to think about this. I'm not going to give you the answer. But so, when we dose testosterone, especially testosterone creams, why don't we put the testosterone cream on the patient's scalp and, to stimulate hair growth? Let you think about that, okay?
The greatest degree of dihydrotestosterone receptors are in the testicles.
There you go. Of course. Right? And the 5-alpha reductase enzyme, resides in the scalp, but not in from below the eye, really a bit below the eyelids, not the eyelids, the eyebrows. So, if we put testosterone on your side or on your leg in the same place, you're going to grow hair. If we put it on top of your head, we're going to lose hair. As far as testosterone therapy is concerned, of course, as you've heard me say before, we subscribe to the Bing Crosby theory of medicine: accentuate the positive and eliminate the negative. Remember the next 2 lines, by the way, just as an aside: latch on to the affirmative and don't mess around with Mr. In Between. So keep that in mind. So the importance of testosterone in men's health. I mean, basically it's your anti-aging agent, really, in men and women. It improves libido, mood, cognition, aggression, ambition, drive. It reduces heart disease risk, lowers LDL, raises HDL. It forms proteins in the liver. It's a sexual organ function. Bone marrow stimulates bone marrow cells, increases bone density. If you'll recall, it will, and I may have another slide on this a little bit later, it will increase bone density from the lowest third quartile to the highest quartile by about 1.5% in the lumbar spine and about 1% in the hip. It helps the kidneys stimulate erythropoietin, and it increases muscle mass, volume, and maintenance. Okay, and one of the complaints about the semaglutide is that you lose muscle mass and it doesn't come back. But there's ways around that. Have you run into that at all?
Yes.
What are you doing about it? Anything?
Which part? I'm sorry, sir.
So, semaglutide, one of this quote unquote side effects is you lose muscle mass along with, fat.
This is ridiculous. We think this is an absurd assertion. People who have significant appetite suppression, who are not then therefore engaging in any physical activity, they are just not eating, are naturally going to lose muscle mass and become deconditioned. We see this all the time. So this muscle mass loss we see largely as a secondary effect of the person just not eating properly. They're not consuming sufficient amounts of protein, and they're not engaging in proper resistance training at the same time that the GLP-1 is affecting proper appetite suppression. So we just see this as a natural secondary response to the person not training properly and eating properly. We do not see disseminated muscular atrophy from the GLP-1 receptor agonist. I don't know where this guy who's making all this
I know. There's a whole bunch of them there. There was Ozempic face and Ozempic finger and all that kind of nonsense too. But if someone brings it up, we usually recommend some creatine, and that'll take care of it. Okay. Yeah. 5 grams, I think, is the dose, 1 to 3 times a day.
Yeah, absolutely. And they have a liposomal creatine out now, sir. I'll send you the company information. It's really, really good. People who have some GI upset with some of the creatine, that this tends to be much better for them. So I'll send the information if you're interested.
Okay. All right. So early life influences of testosterone, the first 2 trimesters of pregnancy. Testosterone is intimately involved with brain development in utero. And excess testosterone is actually involved, is one of the sort of triggers for autistic behavior. It helps with develop of male external genitalia. Within the first 6 months of life, usually the babies have a mini puberty, and the genitalia becomes more noticeable and prominent, and before it sort of, retreats. And then in puberty, of course, testosterone levels increase 10 to 20-fold. You get the sex characteristics develop, facial hair, growth spurts, and you get a 15 to 20% rise in hemoglobin from erythropoiesis. So those are the effects of testosterone in early life. This is just a little fun fact. Take a look at your hand. If your exposure to testosterone in utero, your ring finger should be longer than your index finger. And they call it the 2 to 4 ratio. So for males, the 2 to 4 digit ratio should be less than that of a female. So those that are allegedly gender confused, if you take a look at their hand, and you can tell if they are or not. How do you like that one? So you got that one?
I'm noting that down right now, sir.
Okay. So testosterone levels in amniotic fluid will grow the ring finger much more greater than the index finger. So females, go take a look at Tina, look at her hand, and you'll see that her index finger and ring finger are actually just about the same length.
Wow.
If they're not, she may have had a change in life somewhere along the lines. I don't know. Anyway, prenatal androgen levels are inversely correlated with social and language skills. Adequate testosterone in utero results in, and these are behaviorals that happen with the autistic kids. Eye contact at 12 months, vocabulary beginning at 18 to 24 months, social skills within 4 years, and empathy at 6 to 9 years. Fetal androgen levels are positively associated with autistic traits, genes, genetic issues, and higher rates of androgen-related conditions in females, mostly polycystic ovaries. So, which is common in the autistic girls. This is just a chart of the pubescent testosterone levels are increased an average of 256% in autistic children versus normal children, and the FSH is decreased on average 35%. So just to keep that in mind. Testosterone sufficiency in men, we get improvements in memory, cognition, brain function, brain epinephrine, sense of well-being, oxygen uptake, muscle tone, skin turgor, sexual performance. It's an anti-inflammatory. It increases the anti-inflammatory cytokine interleukins 10, muscle mass, as I noted, bone density, and endurance. Sufficient testosterone will diminish psychiatric issues, psychologic issues, anxiety, depression, mood swings, long-term dementia, Alzheimer's disease, multiple sclerosis risk, dry eye syndrome, LDL cholesterol, fibromyalgia, pain syndrome, skin turgor, clotting factors, sexual dysfunction. It will diminish inflammatory cytokines, interleukins 6 and TNF alpha, joint pain. This is the same issue, what I just showed you in the little charts there, just in the list form if you need that. Skeletal muscle correlates significantly with testosterone levels. Physiological testosterone levels improve BMI and leg press strength by 48%. Lean body mass, body fat, and fat mass are directly associated with testosterone levels. So the lower the testosterone, the more fat you are. This was a study done that showed significant reductions over 6 months in weight, abdominal fat, gluteal fat, total fat, and BMI with adequate testosterone levels. So adequate testosterone levels in these studies are usually about 600 total for males and 2 to 4% in the free. That's what they define as adequate. Testosterone parental will decrease lipid levels, total cholesterol. It will improve HDL, decrease serum albumin and lipoprotein, parental testosterone at, again, physiologic levels. So approximately 80 milligrams per week for 3 weeks. And by the 4th week, we get a significant change in cholesterol levels. Higher total cholesterol levels and the sex hormone binding globulin are inversely related to carotid artery atherosclerosis. When you go from the lowest to the highest quartile, you get a decrease in carotid intimal thickness by over 50% with adequate total testosterone levels and controlled sex hormone binding globulin. Low testosterone increases the risk of coronary artery disease via the as an anti-inflammatory, and again, as we mentioned, interleukin 6 and TNF alpha. We'll get a reduction in C-reactive protein, which I'm sure you're drawing on every patient at least once. Testosterone levels are inversely related to the severity of coronary artery disease, and cardiovascular and metabolic disorders are common in men with low testosterone. Testosterone therapy decreases cardiovascular risk with androgen deficiency. Supraphysiologic levels actually reduce nitric oxide and increase oxidative stress at the cellular level, leading to mitochondrial dysfunction. So too much is no good. All right. So when we first started doing this way back when you were just a baby in around 2000, our treatment goals were, and this was from your friend, Dr. Rouzier, we would get the total testosterone levels to 1500. That was the goal. And the estradiol level 0. That was the goal. Around in 2013, around Thanksgiving, it was all over the news. A big study came out of the VA in Boulder, Colorado, written by this vegan, that testosterone in the first 75 days caused increased incidence of heart attacks and strokes. It was a big deal. It was on the news. It was in the New York Times. It was all over the mainstream news people. And those of us doing this were looking at each other and saying, "What the hell are they talking about?" Our friend Dr. Smith wrote within 48 hours, had written a 5-page paper, I have it somewhere, with about 50 footnotes saying that, this was all wet. So our friend Morgenthaler, Mr. Androgen therapy himself, went about and looked at the data that was produced by this outfit here, and what he found was that they had what they reported and what the data. This was from their study was the exact opposite. The light gray are the untreated group, and the dark gray were the treated group. And as you can see, death, MI, strokes were all at least half, and all events were half with adequate testosterone versus those who were not treated. This was in the first 75 days of treating patients with testosterone. So, it was misrepresented. And there was in the database, there were 10% of the study group were women. None of that was mentioned. And they revised it 3 or 4 times. The androgen groups wanted them to throw the whole thing out. I don't think they ever did, but it was just kind of like sort of hushed up. And you can still find this online, but it was pretty much debunked. Okay, so testosterone increases bone density. I mentioned it before. I might have gotten the numbers wrong. So it will increase bone density between 1.8 and 2.2%. So when it says BHRT, it's with and without testosterone. And as you can see, that increases the hip and lumbar spine bone density quite nicely. I may have showed you this before. There's a peer-reviewed study, the sports car challenge. So in this, at the very minimum, you can get grant money for nearly anything. So these researchers took about 30 young guys, ages 20 to 29, measured their testosterone levels, gave them a Porsche 911 to drive around for an hour in the city and on the highway, and then measured their testosterone levels again. They had them come back the next day and drive the Toyota Camry, and they did the exact same thing. And as you can see, the testosterone, the sports car testosterone levels pretty much zoomed, and the Camry was, who cares? Okay, so I don't know, it was some sort of social, it was an organizational behavioral experiment, but it just goes to show you that your environment can at least temporarily affect testosterone levels. Metabolism, you can't store it. You do not store the testosterone. Remember, 98% of it is bound to protein, and free and albumin bound testosterone is labeled bioavailable testosterone. You can go, if you have the sex hormone binding globulin and albumin, there is a formula that you can use to get the bioavailable testosterone. I needed to go online for that to get that calculation. If you don't want to do that, we just have the sex hormone binding globulin. It's called the free androgen index. I'll show you how to calculate that in a minute. Sex hormone binding globulin. See, this is one of the things that are overlooked. If you only look at total testosterone and don't look at the free testosterone, you can have a patient with, and we see this, and I'm sure you see it too, with a testosterone of 1,030, but their free testosterone is 1.5. So even though it looks like it's high, it's not getting there. This is the usual culprit here. It's made in the liver, the testes, and the brain. It signals heart, brain, and adipose tissue, and it regulates the bioavailability of target cells. It binds to androgens more than estrogens. So it's also, it also transports estrogens, but the androgens more so. Sex hormone binding globulin will increase as the patients mature, and as you can see, the total and free testosterone, as we all know, falls off after age 25. So high sex hormone lab values, normal lab values are 10 to 57 for males and 18 to 144 for females. You want to keep it in the 40 to 50 range if you can. Like I said, a lot of times you'll find, like yesterday, as a matter of fact, I had a female patient. Her testosterone was 21, and her sex hormone binding globulin was like 130. So 21, is a little bit lower than we like. Remember, our sweet spot for females total is 30 to 40. but with that high sex hormone binding globulin, her free testosterone was actually quite low. I don't know if you remember what the formula was. I usually take the total and divide it by the product of 0.288, that's your conversion factor, times the sex hormone binding globulin. And I'll show you, okay, that's the formula.
Yes, sir. Okay.
Okay. 30 to 100 for males is your normal. About 55 to 110 is our ideal. That's called the free androgen index. And I always forget what the numbers are for females. It's like 0.9 to 8.4, I think, is normal for females, and the optimal is about 2.9 to 5.4. I think I might have it in here. Don't hold me to that. Sex hormone binding globulins will be higher with higher estrogen levels, prostate cancer, osteoporosis, hyperthyroidism, and anticonvulsants. Low sex hormone binding globulin is usually present with high total testosterone, metabolic syndrome, high insulin, obesity, elevated C-reactive protein, triglycerides, and sleep apnea. Okay, items that raise sex hormone binding globulin, again, estrogen, progesterone, and female hormones, thyroids, sea roaches of the liver. That's how they pronounce it in Wilkes-Barre, PA. Cirrhosis of the liver. I forgot that was even in there. Starvation. So, intermittent fasting, anticonvulsants, growth hormone deficiency, St. John's wort, and we use boron. 3 milligrams of boron up to 10 will no, that lowers it. Sorry. And St. John's wort. Boron, it's over on the other side. 3 milligrams is the usual starting dose. On average, boron will decrease sex hormone binding globulin by 50% within 4 to 6 weeks. So, we can affect that pretty quickly. We actually started carrying it in the office now. Some of when women say that it makes their urine sort of pungent. So I'm not sure what to do about that, but a few, not too often, but once in a while, someone will tell us that. Again, lowering sex hormone binding globulin, with higher insulin levels, testosterone, the androgens, growth hormone, hypothyroidism, cortisol, nandrolone, and stinging nettle. So your bodybuilders and whatnot. So, but boron's our go-to when it's high. Okay, usually there's not a reason to try and raise it, but if it's low, it's low. If it's high, like I said, boron's the way to go. Exercise, of course, coffee, caffeinated coffee, increased fiber, decreased sugar. Oral contraceptives will increase sex hormone binding globulin and lose weight. You can raise it with different types of drugs, antipsychotics, antidepressants. Usually what will happen is they'll come in on these things and you'll find that they have a high sex hormone binding globulin. Also in the upper left-hand corner there, if you need to raise prolactin, all of those things will work. Supplements, green tea extract, whole foods, flax seeds will raise it. And other drugs, so your aromatase inhibitors, spironolactone, Evista, I don't know, use that at all?
No, sir.
Okay. Metformin and danazol. So, okay. We'll also raise it. Okay, so this is what we test. We do free testosterone, total testosterone, sex hormone binding globulin. If you get a CBC and chem profile, you get the albumin in there. It's best to do it in the morning before 10 a.m. The insurance companies insist you have to do 2 of them. If your testosterone level is 302, they tell you you're okay and you don't need anything. If it's 299, you do. So, we see symptoms usually up to 600 in some men in total. So our goal now is about 700 to 900 total, 2 to 4% in the free, and about 50 to 110 with the free androgen index. You want to check luteinizing hormone for any secondary characteristics. if fertility is an issue, semen analysis, DEXA scan. If again, if it indicated, remember that if total testosterone was less than 150, that's pretty much your cutoff for frank depression. You also want to check a prolactin level. Well, we do that anyway. And then sometimes you need to do chromosomal studies, Klinefelter syndrome, if you have an elevated FSH, LH, but a low total testosterone.
Doctor, could you mention quickly when you initially evaluate a male, the proper way of distinguishing primary versus secondary hypogonadism based on the behavior of FSH and LH?
I don't have it right off the top of my head. Let me go find my chart and I'll get that for you. Okay.
Thank you, sir.
All right. Does it really matter?
No, it doesn't. But they asked in I was doing a continuing education thing for Viking, and there were 5 physicians there, and about 7 or 8 mid-levels, and I was doing a primer on testosterone, and they asked me, hey, can you help us differentiate primary versus secondary testosterone, just primary versus secondary hypogonadism, and what the role of examining FSH and LH and making that differentiation is? And I said, let me get back to you.
But I just said to you.
I'm sorry.
All right. Send me a text message when we're done later, and I'll make sure I don't forget to do it. Send it to you. Okay.
Thank you, sir.
Okay. So remember, eliminate the negative. So these are the things that we come across with adequate testosterone therapy. So sleep apnea is allegedly a contraindication to testosterone therapy, which I'm not sure why. Acne, that would be an overdose reaction or a sensitivity reaction. Gynecomastia, of course, erythrocytosis, which is confused with polycythemia vera. I think we've talked about that before. And of course, benign prostatic hypertrophy and prostate cancer. And we now know that testosterone does not cause prostate cancer. We can get testicular atrophy with it and some infertility. And in the cardiovascular issues, remember, it lowers LDL, it lowers the incidence of cardiovascular disease. It's these knee-jerk reactions. You take a look at the CBC, and as you know, the hematocrit and hemoglobin will increase due to the erythropoiesis that's stimulated in the kidney. And they're getting a little bit better. They got a new, younger endocrinologist at the VA now, so they're not sending every guy who's got a hematocrit over 50 to go get a bone marrow anymore. We managed to stop that finally. It only took 8 years. So, right. So, I used to send notes with him. He does not need a bone marrow. Right. So traditionally, so the books that I've seen say if the hematocrit's over 50, you have to stop the testosterone. No, you don't. And in higher elevations. So where I lived before and now, 55 is not unusual. Reno's at 4,500 feet. So the higher the elevation, the higher, the hematocrit is just naturally. But you look at the CBC, as long as the platelets and the white blood cell counts are normal, it's from the testosterone. And quite frankly, you're not going to see polycythemia vera 3 times in your whole life. It's a blood tumor. It's a genetic tumor. And the EPO levels are actually low, not high. In testosterone therapy, the white count, the platelet counts are all normal. The genetic markers are negative, and the erythropoiesis EPO levels are high. That's the difference. Okay. So these are the big scares, for prostate cancer, polycythemia vera. These are my conclusions with the references here. High testosterone levels do not increase the risk of prostate cancer. Testosterone therapy does not increase the risk of prostate cancer. It does not increase the progression in men. It does not exacerbate metastatic cancer, and it doesn't cause rapid progression and death in men either. It doesn't do any of those things. Again, the conventional wisdom, advanced prostate cancer is treated with androgen deprivation therapy. They use LHRH, anti-androgen agonists to block testosterone. There is a warning label on it, but again, it was one of these knee-jerk reactions. After that vegan study came out, they put a heart warning label on it, and once those labels go on, they never come off, even though the whole thing was bogus. Testosterone is contraindicated in men with or even suspicion of prostate cancer. That's a warning label, although we know now that that's not true. Higher androgen concentrations cause a greater growth of androgen-sensitive prostate cancer cell lines. That was the theory anyway. It actually came from the study from Huggins and Hodges in 1941. They actually studied 3 patients. They gave 3 patients with prostate cancer. They gave them testosterone for IM for 14 days. One got better, one got worse, and one had no change. So they decided that testosterone therapy increased prostate cancer by 33%. Okay, so 3 patients, right? And that was the conventional wisdom from 1941 until the mid-90s. When Morgenthaler and his group said, wait a minute, this doesn't make any sense. Right. Think about, we talked about this before, right? Testosterone levels are high and low in who gets prostate cancer, young guys or old guys?
The old guys.
Who's got high testosterone levels, young guys or old guys?
Young guys.
So how come the young guys don't get the prostate cancer, right? I mean, it just never made any sense. Again, multiple reports revealed no prostate cancer progression with testosterone therapy. Some patients have improvement in pain. It's an anti-inflammatory. There's no increased risk of prostate cancer, and there's no reduced risk of prostate cancer in men with low testosterone therapy. So, you take it away, it reduces their risk. No, that's not true either. And then you make them depressed. Here's one of the studies. The highest 20% of testosterone versus the lowest 20% levels, there's no difference in the incidence of prostate cancer. So here's another study. Does it increase the risk of prostate cancer? And actually, as you can see, the testosterone related patients had a lower long-term risk of prostate cancer than those that didn't have any. The theory here now is that it's a saturation model, that the testosterone will fill up the androgen receptors to a certain point, and after that, there's no effect on prostate growth. The PSA that's sort of been pinned down to is actually that where the androgen receptors are saturated is at 2.5. Okay, castration causes prostate cancer to regress. Higher testosterone levels fail to cause prostate cancer to grow, so that there's sort of a paradox. See it like our picture here, that's me and Felice Gersh, you know her? Paradox. There's 2 doctors there, right?
I don't know who Dr. Dersh is.
She's pretty good. She does a lot of female hormone teaching. She's really good. And she's a great lady. Yeah. She comes. She's one of us. Even though she's an MD, we don't. I keep telling her we don't hold it against her. Yeah. So I had a little interesting segue from my friends at the AOA this week. So I'll tell you about that when we're done. Maximal stimulation of prostate cancer is reached at a relatively low levels of testosterone, and anything higher is you don't get that. So again, PSA at about 2.5 is the saturation point. So low levels with lower PSAs, you can still get some so stimulation, I guess you would call it. Testosterone normalizes PSAs, And to correctly interpret the PSA, you need to know whether the serum testosterone level is above or below the saturation point. So once it gets to 2.5, you're golden. So this, progression, increase, and whatnot, it may have to do with testosterone, prostate cancer advancement, but it doesn't have anything to do with the testosterone itself. This is a radical prostatectomy. Testosterone after radical prostatectomy reduces recurrence and delay time to recurrence. No identifiable general health complications were associated with it. And as you can see here, recurrence with the testosterone group was 7% versus 12% in the untreated group. Here's another study looking at the same thing. Follow-up more than 2 years. High-risk patients after radical prostatectomy, Gleason scores 8 to 10. 4% of those men had a recurrence versus 8% in men that with low testosterone levels. So you can see that 4 times as much. So, okay. So conclusion: testosterone therapy in men with untreated prostate cancer is not associated with prostate progression. Does it increase the risk of progression? And the answer is there. You see here, there's no difference in progression between the two groups, men with and without testosterone therapy. The mean PSA didn't change, at least significantly. Prostate volume was unchanged, and all these men had at least 2 biopsies. So what to do? There's a lot of numbers there. As you can see here, first of all, radiation therapy actually had the lowest recurrence rate post therapy. Active surveillance and radical prostatectomy so active surveillance is basically don't do anything. Radical prostatectomy is again, the recurrence rate is slightly higher than doing nothing, but about the same. And as you can see here, at 5 years, there's really no difference in recurrence rate with anything that you do. So, okay. So when you use these LHRH agonists to treat advanced metastatic cancer, the men get a flare, a testosterone flare of 40 to 300% in the first 1 to 3 weeks, and there was a fear that created a exacerbation, and that proved to not be so either. Okay. So there's a bunch of studies here that show that. No evidence of increased risk associated with the testosterone flare. Did you know about that, by the way? That was kind of news to me too. So I didn't really know about that. The testosterone flare occurs with or without anti-androgen therapy. PSA flare has not been demonstrated in the random clinical trials to worsen the outcome. Okay, no evidence for increased risks associated with testosterone flare, and that would sort of give us a clue that that saturation model from Morgan Teller is probably correct. Yeah. I said once it gets over 2.5, the PSA, it doesn't really matter. Rapid progression and death, pretty much the same. Patients that had metastatic prostate cancer, therapy over 12 months, and the testosterone levels went from 200 to 1100, probably a little bit too high. The PSA went from 3.1 to 13. And up to 80 in the metastatic group. What's the BCR group here? Recurrence and metastatic group. Okay, so the BCR is just a recurrence group. They all had symptomatic relief and well-being. Overall mortality was 13%, and the prostate-specific mortality was 4.5%. So 3 men developed a significant bone pain at least 8 months down the road. No cases of rapid onset conclusions of vertebral collapse, etc. One of the 3 deaths during the testosterone therapy was prostate specific, but I think it was pretty much a good look. So here's Teddy. I've told you about Teddy before, right? So, yeah. Okay, he's 95 years old. His wife had passed away 8 years ago. His only interest was playing Texas Hold'em, in a local casino. We'd say to him, how'd you do today? I called at his office. He said, well, they took my allowance, but they fed me. And so I'd say to him, so you lost $300 they gave you a $12 hamburger. He says, yeah, but I had fun. So Gleason score of 10. He actually had prostate cells in his right lung. His PSA was 46. Total testosterone was also 46. Free testosterone was basically non-existent. He was treated with Lupron. He complained of he wasn't getting out of bed. He wasn't eating. He said to me, he says, I'm still breathing, but I'm really dead. He lost a lot of weight, and he says, really, if I can't go to the casino, I want to pull the covers over my head. So testosterone indicated here. Remember, normal physiologic levels of androgen inhibit the proliferation of prostate cancer. Low-level androgens are essential for initial growth of prostate cancer cells. So, low androgen levels actually stimulate prostate cancer cells. I mean, this was Teddy on a good day. This was it. He would sit up. He might turn the TV on, and that was about it. So we got him, we did eight weeks of, we give him testosterone cypionate. I would probably do it a little bit quicker because remember, this has a half-life of 12 days. And, we're essentially starting over again, but we did 400 milligrams. This was a protocol we got from, I think it was Montefiore Hospital, 400 milligrams IM every 2 weeks. And then I had an oncologist that gave him an anti-androgen. Within 8 weeks, his PSA had decreased by 50%, and they did an MRI on it, and the tumor burden had actually decreased by 50%. This was 8 weeks after we began the therapy. He's in a restaurant. These are his granddaughter and great grandkids, and so I think he went from this to this within 8 weeks. I think we did him some good. He did pass away during the lockdown. He pulled the sheet, he said he had enough. His words were the casinos will never open again. And it was worse than Pearl Harbor. He was a World War II vet. So that was Teddy. All right. So did we kill him or did we do him some good?
You definitely did him wonderful things.
Yeah. Okay. So here are our conclusions here. High levels of testosterone do not increase prostate cancer risk. Testosterone therapy does not increase the risk of prostate cancer. It does not increase the risk of progression. It doesn't exacerbate metastatic cancer, and it does not cause rapid progression and death. So this is how to use it, by the way. So for radical prostatectomy, you need to know when the PSA is undetectable, 3 months post-op, we can start low-level testosterone levels. X-ray, again, 3 months post testosterone levels. Active surveillance, meaning we doing nothing. You can expect the PSA to rise somewhat over the next 3 to 6 months. You can begin immediately. Post-op or with radiation. Mets will recur with or without testosterone therapy, and the metastatic disease, the PSA is probably high to begin with. Sort of use your intuition there. So that's kind of a roadmap for what.
I'm sorry, Dr. Clearfield, I didn't mean to interrupt you. Go ahead.
Good.
No, so 3 months after radiation or brachytherapy, if the PSA is undetectable, you can then begin.
Right.
If it's low. Okay. All right. So
yeah, it's usually less than like 0.1 or lower.
Okay.
Not 0.1, 1.0.
When you say low levels of testosterone, what would be your starting dose, Dr. Clearfield?
So for somebody like Teddy, I think we gave him 40 milligrams we did it every 2 weeks. We did 400 milligrams every 2 weeks. So that was actually a pretty good dose, but you have to remember we were like starting over again. I would do 40 to 80 milligrams every week.
40 to 80 a week. Okay.
Okay. That's IM. Okay.
Mm-hmm.
Okay. This is just an aside. I came across this, I think from Dr. Hertog. This is a suppository you can use 15 days out of the month for benign prostatic hypertrophy. It's a suppository with ichthyol and progesterone. He states it reduces prostate volume 30 to 60%.
Does he have like a mad scientist?
Yeah, he's a little, he's a little bit crazy, you know, he's got that sort of French accent, and, you know, he does a lot of crazy things. So I just throw that out there, I when I was going through this, I found this in my notes. So I'll have it here so it doesn't get lost. Okay. I don't know if anybody's ever made this stuff. So
is that even available in the US?
Yeah, I think so.
Okay.
I'll ask Mike Beamer. I'll see if he can make this for me. Okay.
That's great.
Okay. I'm gonna have to quit here because I have to be in 8:30. Okay.
Yes, sir.
We'll pick this up. Okay. Is it okay? So let us I want to, what do I want to do here? I want to stop the video. How do I do that? Hit the escape, right? I have to stop the share. There you are. I'm having a brain freeze here. How do I do this again?
You just go to I think in your controls on the bottom, not the slideshow, but if you go through your Zoom controls on the bottom, you should be.
Yeah, I'm not seeing them. How do I bring them up?
How about that? Like on the it's either on the very bottom right, it'll say leave or end.
Yeah, I know, but I'm not seeing that. I'm not seeing that strip here.
Oh, that's strange. How about if you just hit if you hit escape and get out of the get out of the presentation altogether, and then you'll get to your home screen. Then click on the Zoom icon, and then you'll see the meeting controls where you can just end the meeting.
Oh, there we go. Okay, it stopped shared. I remember that. Okay, there we go. Okay, questions?
No, sir. No, that's awesome.
Yeah, okay. So how am I doing so far?
Perfect. Awesome.
Doing good.
You started the show.
I know a lot of I know we've seen a lot of these, but doesn't hurt to review.
Oh yeah, no, it's great.
Yeah, how you doing?
Doing well, sir. Doing well, thank you. Just